Well, good morning, everyone. Welcome to the final day of the Pharmacotherapy prep course. I'm glad you guys all stuck it out and are with us here this morning. I'm Shannon Finks. I'm your moderator for this session, and I'll also be the speaker for Cardiology I. So is it 9 a.m.? Shall we go? All right. Well, unlike Richard Nixon, I am not conflicted and needed to disclose that. This morning we're going to be talking about, I'm going to be spending some time more on the acute care side of cardiology, where Dr. Wiggins, your second speaker, will be focused more on the chronic care issues of cardiology. And I will tell you right now that we do not have time for me to go through primary pulmonary hypertension or pulmonary artery hypertension. There is an excellent resource in your chapter that goes through this. However, it's my opinion that my time is best served you today by going through the more common cardiology acute care issues. And if I were you and I were studying for this exam, I would focus on ACS and acute decompensated heart failure and maybe some of the arrhythmias before I would study something that is a little bit more subspecialized. Your guidelines or your chapter is current with the STEMI 2013 guidelines, the unstable angina non-STEMI 2012 guidelines, and the 2011 PCI guidelines as well. I am a visual learner, and so for those of you who do not practice in the area of cardiology or could care less about acute coronary syndrome, I think this is really important, because if you get the pathophysiology down, you're going to be able to distinguish then between the treatment differences between the acute coronary syndrome. So I'm a visual learner, made this slide for you. We're going to talk about it briefly. But acute coronary syndromes are basically an umbrella of events that include unstable angina, non-STEMI, which is a non-ST segment elevation MI, and STEMI, which is an ST segment elevation MI. And it starts with coronary artery disease. So you have a patient with atherosclerotic plaque, and for a variety of reasons that plaque may rupture. And once that plaque ruptures, platelets are called to the site of action. If left untreated, they are allowed to activate and aggregate, and they can cross-link with fibrin strands to form a totally occlusive clot. And I'm going to use this pointer, but on this side. Can you guys see if I use the pointer on this side of the screen? I'll try to do it on both sides. But can form a total occlusion of the coronary artery. Now what happens is that blood flow then is deprived of the myocardial tissue beyond where the clot is, and cells die. When cell death occurs, the tissues lyse enzymes, and that is why you always have positive biomarkers in an ST segment elevation MI. Also, it is depicted upon EKG. So a total occlusion of the coronary artery will actually look like an ST segment elevation on EKG. Chest pain-wise, you may not be able to tell the difference between unstable angina, non-STEMI, and STEMI, but these are differentiated by their biomarker status and whether or not, and what they look like on EKG. So this total occlusion, this is a very acute injury. This is very important to take care of very quickly. We're going to rush these patients to the cath lab as soon as we can, because time is muscle, and we want to open up that total occlusion. We want to open up that artery. And it's different from unstable angina non-STEMI in that unstable angina non-STEMI is a very platelet-rich clot. We may not take these guys immediately to the cath lab. We're probably going to take them soon, depending upon the risk. But we're going to give them antiplatelets, antithrombotic agents, and we're going to try to minimize the size of that infarct. They look the same on EKG. You may have ST segment depression. You may have some unique changes from normal in this instance. But the way to tell the difference between the two of them is that for non-STEMI, you do have cell death, and there is a positive troponin in non-STEMI. Let me advance my slide here. Okay, so your goals of therapy are slightly different, because STEMI, again, and I'm going to start with STEMI. STEMI is that very acute problem. Cell death is occurring, time is muscle, and so our main goal in STEMI is to restore patency to that infarcted area of the heart. And we do that by either opening up that artery mechanically with PCI, or we do so with fibrinolytic therapy. And there are differences between the two. Hands down, if you work in a city or a center where a cath lab is open 24 hours a day, hands down, PCI is preferred. PCI will restore blood flow almost 100% of the time if they can get into that artery, whereas if you give lytic therapy, it only restores good blood flow about 60% of the time. So trials that have been done show PCI is the way to go, but it may not be possible if you live in a rural setting where a cath lab is far away, or it may not be open 24 hours a day. And there's some national benchmarks, but one definitely that I want to point out is that the new STEMI guidelines say specifically that if your patient who has a STEMI cannot get to a cath lab where PCI can be performed within 120 minutes, lytic therapy is preferred. Now that's given that there are no contraindications. These other two time frames are national benchmarks. So you have a door to needle time, meaning the time a patient hits the door with their STEMI, to the time of drug administration, lytic administration, and we want that to be less than 30 minutes. And then secondly, a door to balloon time. We're shooting for them hitting the door with their STEMI and getting that artery opened up with PCI in less than 90 minutes. And of course, our goal in STEMI is to prevent complications, heart failure being a major complication of MI, and we want to control their chest pain and symptoms. Non-STEMI is a tiny bit different in that, well, not a tiny bit, it's different. We don't take these patients immediately to the cath lab, but we do start antiplatelet therapy and antithrombotic therapy fairly early on. And we'll make a decision on whether or not these patients are good candidates for PCI by using some risk-benefit information. Our goal in this is to prevent total occlusion from occurring, and we want to control their chest pain and associated symptoms. So everybody who has STEMI ultimately or ideally are going to the cath lab. When you have a patient or a patient case that is unstable angina or non-STEMI, you get the decision, am I going to medically manage these guys or am I going to take these to the cath lab? And the way we figure out clinically if a patient is a good candidate for a cath lab is by using a risk scoring system. This is an example of the TIMI risk criteria. It's in your chapter. Don't memorize it. Know that the take-home message is that there are a couple of risk calculators. The take-home message is the higher risk patient is going to benefit from PCI. So what TIMI does is you get basically a point for each of these, age greater than 65, and then you add up the points, and what it tells you is the likelihood that that patient is going to suffer death, recurrent MI, or severe recurrent ischemia within the first 14 days. There's another risk calculator called GRACE, the Global Registries of Acute Coronary Syndrome. Again, the take-home message is the high-risk patient goes to the cath lab. So once you have that risk score, the physician looks at anatomical features and ischemia features and determines whether or not they're high risk or low risk. So if you have a high TIMI score and you are having angina at rest and you had a recent PCI 6 months ago and you've got positive troponins, you're going to the cath lab. These guys are somewhat easier to figure out. And so if you're given a patient case where they're very low risk score and that is calculated for you, they don't have any chest pain at present, the patient doesn't want to go, or the physician says, it's too high risk for them. These are easy. These are your medically managed patients. And this is for unstable angina non-STEMI. Okay, so while everyone is trying to figure out whether or not we're taking this guy to the cath lab immediately or whether we're going to medically manage them, everyone in acute coronary syndrome gets some initial therapy. And MONA plus B, MONAB, however you want to remember that, these are the therapies that are usually given within the emergency department. Aspirin and beta blockers being the two that are mortality reducing. Morphine is an anxiolytic, and it reduces heart rate, reduces oxygen demand, myocardial oxygen demand in that way. Oxygen obviously theoretically could increase oxygen supply because there's that oxygen mismatch, supply-demand mismatch in the acute coronary syndrome. And nitroglycerin is a drug that we use also to relieve chest pain early on. I will point out that it's been about 6 or 7 years since the counseling on sublingual nitroglycerin has changed with the guidelines. So if you're not aware that we no longer counsel patients to take 3 and call an ambulance, it is take 1 sublingual nitroglycerin. If your pain is not relieved, call 911. The rationale behind that is because time is muscle, and we want them to arrive at the emergency department earlier so that we can appropriately triage them for appropriate care. All right, so this is where we start to get into the nitty-gritty and where I feel like a lot of your questions may come from. So I want you to understand that in ACS there are 2 major players in clot formation. There is a platelet pathway up here, and there is a thrombin pathway down here. And we're going to give agents that affect both pathways. So antiplatelet agents, everyone is going to get aspirin. Everyone is going to get a P2Y12 receptor antagonist. So that it doesn't matter if it's STEMI or unstable angina or non-STEMI. Everyone is going to get dual antiplatelet therapy. You may have an instance where you give a glycoprotein inhibitor. So as far as antiplatelet therapy is concerned, know that you may choose 3 different classes of antiplatelet therapies to administer to your patient, or you may have to discern if this is appropriate or not, given 4 choices on the exam. As far as antithrombotics are concerned, you're only going to give 1. So your options of anticoagulant therapy are unfractionated heparin, low molecular weight heparin, fondaparinux, and bivalirudin. All are class 1 according to the unstable angina non-STEMI guidelines. A lot of times formulary decisions dictate which agent, or physician preference dictate which agent is chosen. But just know that you could choose 3 different classes here, but only choose 1. So if you're given a case where there's more than 1 anticoagulant, you know to eliminate that response. Okay, so here are the class 1 recommendations from current guidelines of agents of choice for unstable angina non-STEMI, and this is from the 2012 guidelines. As far as anticoagulant therapy is concerned, all 4 are options if your patient is going to the cath lab. And when you look at antiplatelet therapy, if your patient is going to the cath lab, all 3 P2Y12 receptor antagonists have data in this setting. So you might choose clopidogrel, you might choose prasugrel, you might choose ticagrelor. But all 3 are class 1, and there's not preference that's given for one over the other in this particular setting according to the guidelines. They're all class 1. So we'll get into why you might choose one agent over another in a minute, but I just want to give you the 50,000-foot viewpoint before we get into a little bit more specifics about these agents. If your patient has unstable angina and they're medically managed, notice that bivalirudin falls off of antithrombotic choices, and notice that prasugrel falls off in your antiplatelet category. And this is important only because prasugrel was not studied in an ACS setting where patients were medically managed. And so that's why it does not receive a class 1 recommendation in this instance. STEMI, let's talk about STEMI. That was for unstable angina, non-STEMI. Let's talk about STEMI for a second. If your patient, in your case, gets a lytic, your P2Y12 receptor antagonist is going to be clopidogrel. And the reason for that is that it's tried and true. It's been studied for many years. We have much more data with it. We don't have data necessarily with the newer agents in lytic therapy. So that would be an easy answer to pick out on an exam. If you do give lytic therapy, know that your anticoagulant has to be given, if unfractionated heparin is chosen, has to be given for 48 hours after that lytic. If you choose fondaparinux or enoxaparin, that therapy is continued until discharge or until 8 days, whichever occurs sooner. So anticoagulant therapy always goes for a longer time frame with lytic therapy. If your patient goes to primary PCI, again, all 3, clopidogrel, prasugrel, and ticagrelor are options. And the 2013 STEMI guidelines recommend heparin or bivalirudin as your antithrombotic therapy. All right, so don't get nauseated by this table that's included in your chapter. I'm going to point out some major differences between the three P2Y12 receptor antagonists in the hope that this will help you digest some of this material. So when you're given a case, and let's say it's a unstable angina, non-STEMI patient, they're very high risk. They are going to the cath lab, and you have choices to pick which antiplatelet therapy. All three are options according to the guidelines. So you have to know details about the case. Maybe there's a contraindication to one of the therapies, or maybe one is preferred in renal disease, for example. So if the patient has renal disease, I'll tell you severe renal disease, clopidogrel is going to be your option. For ticagrelor, let's start on this side of the column. For ticagrelor, I told you everybody gets dual antiplatelet therapy, and for the majority of patients, dual antiplatelet therapy is going to be given for 12 months, and compliance is extremely important. So if you have a patient who's non-adherent, ticagrelor is given twice daily. If a patient misses a couple of doses of dual antiplatelet therapy, it drastically increases their risk for stent thrombosis. So this may not be your agent of choice if you have a non-adherent patient. It has an absolute contraindication to intracranial hemorrhage, and it's contraindicated in severe hepatic disease as well. It has drug interactions. It is primarily metabolized by 3A4, so that's another reason why you want to pay attention to other drugs that are given and if given a patient case there. Interestingly, in the Plato study, those patients receiving higher doses of aspirin did worse. The Plato study compared ticagrelor to clopidogrel, and ticagrelor beat clopidogrel except when patients had higher doses of aspirin. So there is a package insert warning that says high doses of aspirin reduce the effectiveness of ticagrelor, so do not give greater than 100 milligrams of aspirin with this drug. The exception is that first dose of 325 that we give everybody who hits the door. So if your patient is on 325, hopefully they're not, but if they are, don't choose ticagrelor. Prasugrel is limited in that it is only indicated for those patients presenting with ACS who go onto the cath lab. We talked about that just a second ago. It also has some dosing limitations based on weight and age, and so if your weight is less than 60 kilos, the package insert says give 5. If you're greater than 75 years of age, there's a black box warning about intracranial hemorrhage, and the take-home message is, as you age, the risk of intracranial hemorrhage obviously increases, and this drug is a pretty potent antiplatelet agent. And there is one caveat: if your patient has diabetes or STEMI, the physician can still give prasugrel, but it's a black box warning to be aware of. Clopidogrel, of course, we're very familiar with. The only thing that I want to mention about it is the package insert still says, as far as drug interactions are concerned, potent inhibitors of 2C19 you want to avoid. So esomeprazole and omeprazole are the two potent 2C19, and that is package insert data. And if your patient in your case is going to surgery, the one with the longest surgery hold time is prasugrel, and you have to hold it for 7 days prior to going to surgery. All right, so Table 8 included in your chapter is just a summary of dosing for antiplatelet agents and anticoagulant agents. And it goes through where they are in the ACS spectrum, if they're ACS and they're going before the cath or after the cath. And what I think you should focus on is knowing all the loading doses. So clopidogrel is 600 milligrams, prasugrel is 60, and ticagrelor is 180. I mentioned earlier that if your patient has STEMI and receives a lytic therapy, that clopidogrel is your choice. And in that very instance, you would reduce the loading dose. If your patient receives a lytic, clopidogrel loading dose goes down to 300 if it's within 24 hours of receiving that lytic, and then it goes, after 24 hours, it goes back up to the normal 600 milligram load. Now the guidelines, most of the guidelines say it is reasonable to use 81 milligrams of aspirin in preference to higher doses. And this is really nice clinically because we used to chase down physicians and we used to give varying doses of aspirin based upon what type of drug-eluting versus bare metal scent, and we would give it for 3 months or 6 months. It's now easy. It's 81 milligrams for everyone. And that helps with ticagrelor too, and not being a contraindication. Your length of therapy is another thing that you need to be aware of. And if your patient has an ACS, your length of therapy ideally is out to 12 months. If your patient has ACS and has gone to the cath lab and they receive a stent, the length of therapy is ideally 12 months. If your patient has not suffered an acute coronary syndrome, but they are going to the cath lab for an elective case. So this is not an acute problem. They've just been having some chest pain intermittently. We go in, we look at the anatomy, and lo and behold, we put a stent in. This is the only time that you will have a shorter minimum of therapy, and it's with a bare metal stent. If you are giving, or if your patient receives a bare metal stent, it's a minimum of 1 month. It takes about 2 to 4 weeks for that stent to re-endothelialize and decrease the risk of in-stent thrombosis. Of course, with drug-eluting stents, there's drug that's eluting over time, and so we have to give dual antiplatelet therapy for much longer. So when in doubt, choose 12 months. The only time that it would be shorter than that is when you've got a bare metal stent and an elective case, and in maybe someone in that instance who has a high risk of bleeding as well. Okay, so where do GPIs fit in? This is our big gun antiplatelet therapy, and I'll tell you that the earlier trials of glycoprotein inhibition were done in an era where we did not routinely stent patients, and we did not routinely give upstream dual antiplatelet therapy. Also, it was in a time frame when we mainly used unfractionated heparin as our anticoagulant of choice. So modern trials with GPIs have been a little bit, they've resulted in mixed results. The guidelines take into consideration that fact, and they say that we really don't know. It's of uncertain benefit if you're giving dual antiplatelet therapy very early on. But they still have a place, and that place is this. If you have a patient who gets unfractionated heparin, and they are not given upstream dual antiplatelet therapy, and they have high-risk features. So these are the patients who have ongoing ischemia. They may have positive biomarkers. They're high risk. They haven't been loaded. We're taking them maybe to the cath lab. This is the type of patient who might benefit from a GPI. And just know that if you're going to have a GPI, if you're going to choose that option, it needs to be paired with unfractionated heparin. And you have to recognize that the two smaller molecules are renally adjusted. Both of them are. So table 10 is a huge, again, table that reviews the dosing. And don't freak out about the amount of information in this table. It is there for your reference. But I'm going to point out again things that I think are game on for the exam. One thing is that fondaparinux, if you're using it in unstable angina, it's a class 1 recommendation. But in the OASIS trials, when those patients went on to the cath lab, those patients who only received fondaparinux had catheter-related thrombosis, meaning, that's not working so well as my anticoagulant. So the recommendation, even though it's class 1, if you go on to the cath lab, it should not be used as a sole anticoagulant. That's why we avoid it in Memphis. There's no use to give it if we can choose an agent that we're already going to use in the cath lab. And if you do have a patient, though, that gets treated with fonda in a rural setting and then they get transported to a place with a cath lab, then you're going to have to add on additional heparin. So know that. It's a class 3 recommendation in the PCI guidelines. Do not choose fondaparinux if your patient's going on to PCI. I mentioned that in the 2013 STEMI guidelines that they prefer unfractionated heparin or bivalirudin as your antithrombotic of choice. Note, though, that this table gives you some information. This is STEMI with primary PCI. If your patient does not go on to primary PCI, let's say maybe they've received a lytic or something or in the rural setting, note that fondaparinux and enoxaparin have been studied in STEMI, and notice that you have to give a tiny IV bolus before the traditional 1 milligram per kilogram dose that's given BID. So that's just a tiny bolus to get them anticoagulated really quickly, because we've got a total occlusion of the coronary artery. And this is also limited by age. So if your patient's greater than 75, you omit that first bolus of enoxaparin. And this may be too detailed. I don't know that they would ask you this, but I wanted to point it out as a difference, because most people who practice in acute coronary syndrome just know the milligram per kilogram Q12, and this is STEMI dosing. Note that all three, enoxaparin, fondaparinux, and bivalirudin, have limitations. They are renally cleared, and unfractionated heparin is not. And we're also going to talk about lytic therapy just for a moment. So again, the 2013 guidelines say that if you cannot get that patient to a cath lab within 120 minutes, then lytic therapy is preferred. And I haven't seen a lytic given in over a decade. I cannot imagine that there would be more than one question on this, because it's not necessarily contemporary practice, but if you practice in an area where I grew up, rural West Tennessee, then you might. So we will go through it just for harm's sake. Probably the most common lytic given today is a weight-based tenecteplase. It's very easy to give, it's weight-based, and it's given very quickly over 5 seconds. You're done after you do that. Reteplase is slightly, a little bit more cumbersome, but it's still easy to give. It is not weight-based, and it's given 30 minutes apart. It's 2 boluses given 30 minutes apart. And of course, when I graduated from pharmacy school, the only lytic that we had was alteplase, and that's very cumbersome to give. So if you're given a question on the exam about lytic therapy, you're going to have to know absolute contraindications. And some of these just make sense. You know, any prior hemorrhagic stroke, ischemic stroke within the last or previous 3 months, unless if you're using alteplase to treat that ischemic stroke at that time. Any type of AV malformation or intracranial neoplasm, aortic dissection, active internal bleeding, these make sense. The harder part, I think, is going to be figuring out relative contraindications, but I would think that they would have to be pretty black and white on the exam. So hopefully these would be absolute contraindications. Where when we see this in clinical practice, relative contraindications, it's usually a patient has a hypertensive emergency. They're coming in, they've got positive troponins, but their blood pressure is too high to give a lytic therapy, and you might have to, give a dose of some type of antihypertensive to bring down their pressure so that that contraindication goes away. Note that age is not a contraindication to lytic therapy. Elderly patients have received benefit from lytic therapy, and age is not a relative or an absolute contraindication. So let's go into a couple of cases, and we'll apply this knowledge that we just went through. So you've got a 66-year-old woman, a prior history of MI, hypertension, hyperlipidemia, diabetes. She presents with sudden onset diaphoresis, nausea, vomiting, dyspnea. She's got a band-like chest pain that's 8 out of 10 on a pain scale. It radiates to her left arm. She, for the past month prior, has been experiencing typical angina, her typical angina, but it's occurring at less exertion. So she kind of thinks, something's not quite right here. She comes into the ER. She's got ST segment depressions in leads, in her inferior leads, 2, 3, and AVS, and her cardiac enzymes are positive. So what does this lady have? It's a non-STEMI, right? You guys are going to do fine. Okay, so she's on aspirin already at home, Simva, metoprolol, metformin. Her TIMI risk score that's calculated out is 41%. That's high. That's a very high likelihood of her suffering either death or recurrent ischemia or MI within the next 14 days. So which is the best treatment strategy for JD? Are we going to give dual antiplatelet therapy, eptifibatide and fractionated heparin, and send her to the cath lab? Are we going to send her to the cath lab and give aspirin and enoxaparin? Are we going to medically manage her with a GPI, enoxaparin, aspirin, and Plavix? Are we going to medically manage her with dual antiplatelet therapy and unfractionated heparin? And before I see your answer to this, I want to point out something, and this is just good common sense test-taking skills, which I am terrible at, by the way. I do PSAP and recertification hours because it would just send me to MMHI, which is the mental hospital in Memphis, Tennessee, if I had to sit for this exam again. I'm not a great test taker. So rule number one that you need to keep in mind if you're like me is assess the stem of the question. So if the stem of the question is asking you treatment strategy, or if the stem of the question is asking you antiplatelet agent, and then they give you a bunch of distractors of whether or not to go to the cath lab or not, focus on what stem is asking you. And then test-taking tip number 2 is all 4 answers on this exam are going to be plausible, but you're going to be able to probably eliminate 2 of them, at least 2 of them, based upon the details of the case. So maybe there's a contraindication, or maybe there's something that just doesn't make sense because of what you've been given in the case. So pay attention to the question stem and try to eliminate 2 responses. So let's go back to this question again and just look at it and analyze it for a second. There are 2 answers here with medical management. There are 2 answers here with PCI. Now, we already know that she's high risk, so we're going to automatically eliminate C and D, right? So then the question becomes, we know we're going to take her to the cath lab. What do we treat her with? And we've already talked about the fact that everybody gets dual antiplatelet therapy. They may not have started antiplatelet therapy early. That's probably a flawed response. But A makes the best sense given the details of the case. And that is, we're going to give dual antiplatelet therapy. This patient's high risk. We've used unfractionated heparin, so a GPI might be of benefit to her, and the cath lab makes the right answer. All right, so this is a 45-year-old who has an elective PCI, and he gets a drug-eluting stent into his right coronary artery. So which of the following best represents how long dual antiplatelet therapy should be continued? And you can use your cards if you have them. Exactly. When in doubt, choose 12 months. Now, if this had been a bare metal stent and it's an elective case, it could have gone another way. So keep that in mind. And that's only in elective cases. Everybody else gets 12 months or beyond. All right. So when I talk about or when I look at a patient's discharge medicines and I'm doing discharge medication reconciliation and they're post-MI or they're post-ACS, I look for 5 or 6 medicines. So everybody gets a beta blocker, everybody gets an ACE inhibitor, everybody gets a statin, a high-intensity statin, everybody's going to get dual antiplatelet therapy, so aspirin plus 1 of the P2Y12. And the 6th medicine, and it could go either way, is an aldosterone antagonist. So, of course, we're going to start beta blockers. There's a performance measure to start oral beta blockers within the first 24 hours of an ACS. And they are generally continued out. The secondary guidelines, which were recently updated last year, now specifically say give it for 3 years in patients with normal LV function. But if your patient has compromised LV function, meaning an EF below 40, then you're going to continue the beta blocker indefinitely. I might argue that, a lot of these patients who are post-MI have another compelling indication for a beta blocker. So a lot of my patients are just continued on beta blockers, but indefinitely. Everybody gets an ACE inhibitor, especially if they have compromised LV function. We don't start IV ACE inhibitors, but we can start oral ACE inhibitors. And really, ACE inhibitors should be considered for all patients post-MI because most patients have a compelling reason to put an ACE inhibitor on board. So it's not just in patients with low EF. Statins, everybody gets high-intensity statins, and Dr. Wiggins will talk about dyslipidemia, and she'll probably tell you that ACS is one of the compelling reasons to go down to an LDL goal of less than 70. And so this is the 6th medicine, and it's been studied in a couple of small studies. The Ephesus study is one where patients are post-MI, they have LV dysfunction because of that damage that occurred, and giving eplerenone in this instance in patients who either had symptomatic heart failure or diabetes, and they were already on an ACE inhibitor, they benefited mortality-wise from that additional aldosterone antagonist. So you might see eplerenone, and of course we know in heart failure, which Dr. Wiggins will talk about the data with spironolactone as well. All right, let's do one more case in ACS before we move on to heart failure. And that is a 52-year-old male. He's got hypertension, hypertriglyceridemia. He is a smoker. He presents to a major university teaching hospital within 3 hours of when his chest pain started. It's crushing 10 out of 10 substernal chest pain associated with nausea, diaphoresis, shortness of breath. He'd never experienced anything like this before. His home meds were lisinopril, gemfibrozil. His vitals, he's got a heart rate of 68. His blood pressure is moderately elevated, 178/94. He weighs 100 kilos, and on his EKG, he has ST segment elevation in his chest leads. His labs are positive for troponin, and he's given the diagnosis of a STEMI. So which of the following should be done for his STEMI treatment? Primary PCI, abciximab, clopidogrel, aspirin, unfractionated heparin, Retaplace, double bolus with unfractionated heparin, abciximab, enoxaparin, tenecteplase, or pyrufiban, unfractionated heparin. What do you guys think? You guys are going to do great. The answer is A. And let's talk about why the other answers. Answer B would not necessarily be a wrong answer if he presented to a rural institution that did not have an open cath lab and we couldn't get him transferred to a place that did within 120 minutes. But it is appropriate to pair in a high-risk individual a GPI with unfractionated heparin, and this is your dual antiplatelet therapy. So that's great. This here, C is wrong. We don't routinely pair a lytic therapy with a GPI. This used to be a term that has been studied in the past. It was called facilitated PCI, where you were facilitating the lytic with a GPI. And all we know from that is that it increases bleeding and it doesn't give benefit as far as outcomes are concerned. So that's inappropriate in this instance. And then obviously this is not enough antiplatelet therapy on board for this individual. Whew, take a deep breath. We're moving on to heart failure. All right, so there are some hemodynamic parameters that you need to know and understand that they are different in acute decompensated heart failure than they are in a normal individual without heart failure. And the first number that most clinicians look at first when they're trying to decide what therapies to initiate in a patient is a pulmonary capillary wedge pressure. And in someone who is fluid overloaded, they are going to have a high pulmonary capillary wedge pressure, 18 to 30. It's not unusual to see that. Whereas it might be in 8 to 12 in someone like you or me without heart failure, but in someone who is not decompensated, who has heart failure, it's going to be a little bit higher. It's going to be 15 to 18 in a normal, non-decompensated heart failure patient. And this is going to become important because we're going to talk about whether or not what drug to give, do we have adequate filling pressures, and so this is a number that you need to know. The next number that comes into play in whether or not what drug therapy we're going to use is a cardiac index. And if your patient is hypoperfused, a normal cardiac index is over 2.8. You're hypoperfused when you fall below 2.2. That's the magic number. Cardiac output we talk about all the time. All that really is the cardiac index is your cardiac output divided by your body surface area. And so really you only need to be concerned with one of those really. Most people have a body surface area of about 2, so it's roughly, your cardiac index is roughly half of your cardiac output. And your systemic vascular resistance becomes important. A lot of times we can give vasodilators to vasodilate and drop that SVR. And in doing so, it provides a benefit because it will indirectly increase cardiac output. So if you think about the equation, blood pressure is equal to cardiac output times your SVR, sometimes we may give vasodilators to cause an indirect compensatory increase in cardiac output, and your blood pressure will stay the same. Cardiac output is dependent upon your stroke volume and your heart rate, and note that stroke volume is highly dependent upon 3 factors: the innate ability of the heart to contract and afterload and how much volume is on board. And so that's illustrated. I don't want to go back to too basic of information, but I just want to remind you about the Frank-Starling curve. And it's really important for us to understand that a low cardiac index can occur when you have really high volume on board or when your patient has really low volume. And so there may be an instance when our heart failure patient, we don't know exactly what's going on, and we may have to figure out where their wedge is, because if it's very low, we may have to give IV fluids, in fact, to get them back on the Frank-Starling curve and to get them adequate filling pressures. And this will be illustrated when we talk about the cases. But often, and especially in clinical practice, we have to rely on patient symptoms. We don't have pulmonary artery catheter measurements on everyone. So sometimes we have to subjectively look and figure out, are these guys congested? Are they perfused adequately? And most clinicians will, well, my goodness, I did not know that this was animated. Okay, here we go. Most clinicians, if you can ask yourself 2 questions about the details of the case, you're going to be able to classify that patient into one of the 4 heart failure quadrants. So if you can ask, does this patient have congestion at rest? Do they have JVD? Do they have orthopnea? Do they have shortness of breath? Do they have that table that we just skipped over, congestion? If the answer is yes, they are wet. If you ask yourself the question, are they hypoperfused? Do they have mental status changes? Do they have an increasing serum creatinine? Are they cold and clammy? Do they have a narrow pulse pressure? If the answer is yes, they are hypoperfused. They are cold. So most clinicians will put a decompensation into one of these 4 subsets based upon whether or not they're hypoperfused or whether or not they're congested. And treatment will vary upon the quadrant, so that's why that becomes important. So most patients who are not decompensated, and Dr. Wiggins is going to spend some time talking about this, they are in quadrant 1, they're warm and dry. And this is the time when we're optimizing our oral medications. We're going to titrate up on our beta blocker and do all the things that Dr. Wiggins will teach us about in the next segment. It's warm and wet where we see a lot of our patients coming in, and these guys are going to have a high wedge, or they're going to have those symptoms of congestion, but they're perfused. They are not hypoperfused. And in this instance, diuretics, IV diuretics, become our therapy of choice. Now, I'm going to come back to this plus or minus vasodilators in a minute. So note this, and we're going to come right back to it. If the patient is cold, they're hypoperfused, and they're dry, they're in subset 3. And this is where I was talking about. We may have to have those numbers, their wedge pressure, to determine if we need to give IV fluids. But if their wedge is not normal for a decompensated or for a heart failure patient, 15 to 18, they may not have enough volume to get them on the Frank-Starling curve. So we may have to give IV fluids until they have adequate filling pressures here. And the only way you'll know that is not based upon symptoms, but you'll have to have some type of PAC measurement there. If their pulmonary capillary wedge pressure is normal, but they have a really low MAP, we might just have to give vasopressors in that instance, just to support vital organs at that time. But where we probably see, that's probably rare, that's cardiogenic shock type pictures, but where we see a lot of the decision making of how to treat decompensation is whether or not we're going to use an inotrope or a vasodilator. And the guidelines really push for using a vasodilator first. So if you have adequate blood pressure, reach for a vasodilator before you try an inotrope. And there's a star here, and the type of vasodilator too is starred here. And these are arterial vasodilators. We'll talk about the types of vasodilators in a minute. But arterial vasodilators here would be great in someone who has a high systemic vascular resistance, because they might vasodilate a little bit and cause a compensatory increase in cardiac output. And we know that inotropes are associated with increased morbidity and mortality over long periods of time. And so that's why we're choosing a vasodilator first if our patient can tolerate it. Subset 4 is the same thing really as subset 3, except they're wet, and so we give diuretics in this instance. we're going to go through some cases to apply this, but let me just say a quick word about chronic meds in the setting of an acute decompensation. Where possible, you want to continue that patient's ACE inhibitor and beta blocker. We know that when patients come in with decompensation and we take their beta blocker off, these patients do worse. They have increased morbidity and mortality. And so the guidelines say, where possible, keep them on their baseline. This is not the time to titrate up. This is not the time to start a new beta blocker, but if they're on chronic beta blocker therapy, try to maintain that and use other medicines to manipulate the blood pressure equals cardiac output times systemic vascular resistance equation. The exception to that is if the beta blocker was the reason or cause for their decompensation. And Dr. Wiggins will talk about we start beta blockers at a dry weight because we don't want to push them into an acute decompensation. So as long as it wasn't the cause of their decompensation, continue them on. And of course, we know from older data that DIG withdrawal also has been shown to worsen outcomes as well in the acute decompensated setting. Okay, so we have a 72-year-old male. He's admitted for acute decompensated heart failure. He's telling you he's got dyspnea. He used to be able to walk 30 feet. Now he's only able to walk 10 feet. He used to sleep on 2 pillows. Now he sleeps on 4. He's had 30-pound weight gain in the last 3 weeks. He admits to dietary non-adherence. So we're looking at a typical decompensation picture here and how they present to the hospital. He does have a history of idiopathic dilated cardiomyopathy and an EF that's low, PAF, and hyperlipidemia as well. His BNP is elevated. If you use a BNP, the cutoff is 50. If you use pro-BNP, the cutoff is 500. Many hospitals are switching over to pro or N-terminal BNP. They should give you normal values on the exam so you'll know which one that is, but that is indicative of volume overload. His serum creatinine 2, that's not an impressive increase from baseline. His baseline's 1.9. His liver enzymes are, his AST and ALT are normal. We know he's got adequate blood pressure to work with, and his O2 sats are fine, and he's sitting there talking to you other than the fact that he has a little bit of shortness of breath. His home meds are carvedilol, lisinopril, furosemide, Spiro, and DIG. So what is the most important option at this time for treating his acute decompensated heart failure? First of all, what quadrant would you put him in? So what is he telling you? Ask yourself these questions. Is he showing signs of congestion at rest? Yes or no? Yes, absolutely. So we're going to be either in subset 2 or 4. Is he hypoperfused? No, he's not. So he's subset 2. And so our therapy of choice here is IV diuretics. Where these venous vasodilators come in, and we're not there yet with him, venodilators are going to be used. Well, let me come back to that with the next case because that's really going to become important with the next case. But IV diuretics, all patients who are fluid overloaded. When the response to diuretics is minimal, the guidelines say you can fluid restrict them, you can sodium restrict them. It's usually 2 liters and 2 grams. You can up the dose of your diuretic. You can do that by either giving IV boluses or you can give a continuous infusion of an IV diuretic, and we know from the dose trial that there's no symptomatic benefit of one strategy over another. We use IV boluses where I practice at the VA across the street where my husband is. He uses continuous infusions of Lasix, so it's really no advantage one over the other as far as symptoms are concerned. You can also, in diuretic resistance, add a second type of diuretic. Metolazone is probably the most commonly chosen. And then some centers have ultrafiltration, hemofiltration as an option for removing that excess fluid in a heart failure setting. So just a couple of things about IV diuretics, and that is that if you're going to choose Lasix and you go up on the dose, you're probably going to get to a ceiling effect, about 160 milligrams. And so remember, autotoxicity starts to occur somewhere between 4 400 and 600 milligrams a day. So we generally stop at about 160 BID. If we haven't received any benefit from the Lasix therapy at that point, we'll go on to something else. If you do use a continuous infusion, it's dosed at 0.1 milligrams per kilogram per hour. So a lot of our patients in Memphis weigh 100 kilos. So we'll start it at 10. And then a few hours after that, every 4, maybe 6 hours after that, we'll increase it to 20, 20 to 30, 30 to 40, and our max dose is around 40 in that instance. If you choose to add a thiazide diuretic, you can choose either one of these really. Metolazone is one that is commonly chosen to enhance the mechanism of the loop diuretic. The only IV thiazide agent that is out there is chlorothiazide. It's pretty expensive, so we don't generally go to it very often, but we can use it, and we do use it minimally in patients who really have severe gut edema and we don't think they're absorbing anything. So keep that in mind. So, what is the best option for treating this patient? Oh, y'all aren't as aggressive anymore in answering my questions. They must be too easy. Good job. It is C, furosemide. Okay, so now we've got the same patient. He started on a loop diuretic. He's got minimal urine output, though, so he's experiencing some diuretic resistance. His creatinine is bumped a little bit, and he's transferred to the CICU with the plan to give him a dose of chlorothiazide. So we're switching to an IV thiazide. We're hoping that it's going to work fairly soon. But you'll note that his symptoms are getting worse and his O2 sat has dropped. So this is where I was talking about earlier, where IV venodilators may have a role and may come in handy. And I probably just gave you, no I didn't. In addition to receiving IV chlorothiazide, which drug might be of benefit in his acute decompensation? I see many A's. Let's talk about that for just a second. We're here in subset 2 still. Even though he's got a mild increase in serum creatinine, he's probably not hyperperfused at this point. But we're going to examine the benefit of venodilators at this point. So the guidelines say that they can be considered in someone in addition to IV loop diuretics to rapidly improve symptoms. Those symptoms that they're talking about here are the shortness of breath, the O2 sats falling. And what we can do is give an IV venodilator to rapidly reduce that preload and hopefully buy time so that the chlorothiazide will start to work. They're not going to take fluid off, but what it can do is relieve those shortness of breath symptoms and maybe even bypass an intubation. Very rarely this is done, but this is where it fits in the guidelines. And it may be considered, but the key here is that it needs to be a venodilator here. And the only venodilator that we have is nitroglycerin. Mixed arterial and venodilators can be considered if there are persistent symptoms despite maximal loop diuretics, and we'll talk about that a little bit more. And again, let me reiterate the point: when you can use a vasodilator, that's what the guidelines prefer. Okay, so we have 3 vasodilators that are used in acute decompensated failure. They're different in that nitroglycerin is mainly a venodilator. It will reduce preload. It is used in the warm and wet patient. It is used in someone who has an acute coronary syndrome that also have symptoms of heart failure. It is used in hypertensive crises that are associated with heart disease. And it does have arterial vasodilatory properties, but that's really at a high dose, much, much higher, like at 100. So we're going to be using it in this instance for its venodilating properties. Neceritide and nitroprusside are the other 2. They are mixed arterial and venous dilators. They're different, but they have the additional advantage that they can be used not only in warm and wet, but they can be used in cold and wet. And this is the type of situation where you vasodilate and you reduce that systemic vascular resistance, and you can get a compensatory rise in cardiac output. Know, though, that the half-life is very different if you do have a patient who receives Recertified and they become hypotensive. It takes a long time for that to recover. A 20-minute half-life is pretty long. Know that, obviously, in hepatic and renal dysfunction, you're not going to choose nitroprusside as an agent of choice here because of thiocyanate and cyanide toxicity potential. So I think for at least warm and wet, your only answer choice in this instance would be nitroglycerin. And I saw many A cards, blue cards. All right, so this patient does respond to the IV chlorothiazide. We get off 2 liters of fluid, and their weight decreases by a kilogram. We're feeling pretty good about that, and we're watching them. But over the next couple of days, their urine output starts to diminish again. And their serum creatinine, which was a baseline of around 2, is now risen to 4.3. We're wondering, is this because we've over-diuresed them? Maybe we've taken them off the Frank Starling curve because they're hypoperfused now, or they're off the Starling curve because they don't have adequate filling pressures, and we're not perfusing their kidneys. They also have symptoms of hyperperfusion in addition to serum creatinine alone. So he's becoming drowsy, mentally confused, he's cold and clammy. So we know he's hypoperfused, and his blood pressure is somewhat compromised at this point. So this is the instance when hemodynamic monitoring probably becomes very useful. And the guidelines for hemodynamic monitoring specifically say that it's not routinely recommended. But when it should be considered is when you don't know the patient's volume status, when they have hypotension that's below a systolic below 80, or they have worsening renal function during adequate therapy for their decompensation, or they're refractory to initial treatment. And so this is the type of patient that this type of monitoring becomes invaluable on. So we get their measurements back, we get his measurements, and the first number that most clinicians look at is that wedge pressure. He does have adequate filling pressures. He's actually still what we consider, higher. He's got a wedge of 30. Can you imagine? We've already pulled off a lot of fluid already, so he even had a higher wedge when he was admitted. His cardiac index is showing us exactly what we suspected based upon his symptoms. He is hypoperfused, and his systemic vascular resistance is elevated as well. So what quadrant is he in now? One, two, three, four. 4. He's in 4. Okay, so the most appropriate medication therapy now is going to be, let's think about this. Are we going to use an inotrope? Are we going to use a vasodilator, a venodilator? Are we going to use phenylephrine at this point? So you told me that he's in 4, and that is right. And if you notice, we do have a choice, or we could do both. And when we have blood pressure to work with, we're going to choose an mixed arterial venous dilator. So either nitroprusside or Recertified perhaps. But his blood pressure is not that great. So remember that star in that table and those compelling indications to reach for an inotrope. And I think we're there at this point. So now we have to decide between which 2 inotropes to use, either milrinone or dobutamine. The guidelines specifically say inotrope when the patient has diminished peripheral perfusion, end organ dysfunction, particularly if their systolic is below 90. That's where we are with this guy. Symptomatic hypotension. Despite adequate filling pressures, we have adequate filling pressures in him, but we have symptomatic hypotension. He's cold and clammy, mentally confused, or he's unresponsive to, intolerant of vasodilators. Now, we've tried nitroglycerin in him. We're probably not, since his blood pressure is so low, going to be able to use an arterial mixed vasodilator in him. And so now we're going to go to inotropic therapy. So when you have the option between the 2, here are some things to think about. They both are going to increase cardiac output. One is directly, dobutamine is directly associated with beta agonist activity, not the ideal choice for someone we want to continue on a beta blocker because they're going to competitively antagonize each other. And it's been shown that we have to use really high doses of dobutamine to overcome their baseline core egg. And so it's not what I choose first if I can help it because I want to keep that patient on their chronic beta blocker therapy. If they're not on a beta blocker, you may choose to go to dobutamine. Milrinone is different. It's a phosphodiesterase inhibitor. It's going to increase inotropic activity because of its ability to increase intracellular calcium. It's more moderate of a vasodilator. So you're going to have probably a little bit more hypotension associated with this drug than you would with dobutamine. Dobutamine has slight peripheral vasodilation, so you might have some patients who respond to that with hypotension. He's already hypotensive to begin with. But what I want you to pay attention to, and I think is really important, in patients with high SVR, this doesn't matter to me because I know that he's probably going to compensate if I can vasodilate. If this is a moderate peripheral vasodilation, they may even, because their SVR is so high, they may be able to tolerate that without affecting their blood pressure. So I'm not necessarily bothered by using milrinone in him because of his blood pressure alone. Note that dosing, this is renally cleared, milrinone is, and so you want to make sure that you renally adjust if a patient has renal dysfunction, and I think that's all I want to say about that. So what do you choose? Milrinone, I would too. Whew, we made it through heart failure. Let's go on to arrhythmias. We're going to start out with our acute life-threatening arrhythmias, and we're going to review ACLS very quickly. We're going to touch on some ventricular arrhythmias and the treatment of ventricular arrhythmias too, whereas Dr. Wiggins will focus a lot of her chronic arrhythmia management on AFib alone. So the ACLS guidelines were last updated in 2010, so you may be aware of all of these. Atropine is no longer recommended in this algorithm, but the algorithms have changed slightly. They're circular. They are emphasizing high-quality CPR and defibrillation attempts for rhythms that can be defibrillated, and high-quality CPR in rhythms that are not they aren't benefited by defibrillation. So what do I mean by whether or not they can be shocked? Shockable rhythms are pulseless VFib, VTAC. Non-shockable rhythms, or those rhythms that don't benefit from defibrillation, are PEA and asystole. So they're divided into two. You have one table in your handout that is devoted. On the top part, it's the ventricular, the VTAC, VFib algorithm, and the bottom part is the PEA asystole. But a real take-home point here is that drug therapy is not high on this list. If you are given a scenario where your patient has sudden cardiac death and they ask you which treatment is most beneficial and defibrillation is on there and it is ventricular tachycardia or pulseless VTAC or VFib, I would choose defibrillation if I were you. Note that you can give vasodilators after the second shock. So you're going to have 2 minutes of CPR cycling. You're going to do all your interventions within that 2 minutes, but not minimizing compressions, because high-quality CPR is the main focus in defibrillation. After the second shock, you can give vasopressors that shunt the blood to the heart and brain. Vasopressin can be given as an alternative to either the first or the second dose of epi, and epi is your standard 1 milligram every 3 to 5 minutes. After the third shock is when you can consider amiodarone. No drug is given a class 1 recommendation. Amiodarone is 2B. That's because amiodarone has never been shown to improve survival to discharge. So we don't have great data with drug therapy. So whereas amiodarone is probably the best agent to choose, it may or may not affect the end result in a patient's life after sudden cardiac death. Asystole and PEA is the next life-threatening arrhythmia. that you may receive a case on. And the most important thing in PEA asystole is to treat the reversible causes. So those are your H's and your T's, and that are listed down at the bottom of your table here. Hypovolemia probably is the most common. You can hang IV fluids in that instance, but I think that may be the extent of the questions that you would get. I just can't imagine that they'll be asking you what to do in cardiac tamponade. That's kind of out of our area of expertise. Note that in 12 and 14 here it says shock if appropriate. And I already told you that defibrillation doesn't work for asystole or PEA. That is, if you give a vasopressor or you reverse a treatable cause and it becomes then pulseless VTAC or VFib, then you can defibrillate them and move to the other algorithm. The non-life-threatening but still important algorithms that are included in the ACLS guidelines include the bradycardias and the tachycardias. The bradycardia is fairly easy. There's only one drug that you need to know. And you're only going to give it if your patient is symptomatic and unstable. So if a patient has bradycardia but they're stable and they're asymptomatic, you're going to observe them. If they become at any point unstable, then you administer 0.5 milligram every 3 to 5 minutes. The max dose is 3. If atropine fails, you can either try transcutaneous pacing, you can use vasopressor agents such as dopamine or epinephrine. Not one of those is given preference over the other in the 2010 guidelines. The next are probably the most difficult and hard for people to wrap their head around, and those are the tachycardias. So I'm going to try to break this up in 3 different sections. If you have a tachycardia, a symptomatic tachycardia, where your rhythm is regular and it's very narrow, it's most likely an SVT. So you're going to try vasovagal maneuvers in this instance to break that circuit, break that rhythm. Or you'll give adenosine. And if you give adenosine, you guys know this probably from clinical practice, this is a very, very rapidly acting drug, very, very short half-life. You push it extremely quickly, you follow it by an adequate flush, you elevate the extremity, all for it to work about 6 to 7 seconds and try to break that rhythm. Only use it if it's narrow and believed to be an SVT. Know that there's drug interactions with adenosine, and that is that if your patient is on theophylline, caffeine, or theobromine, you'll have to increase the dose. Generally, it's 6, 12, and 12. That's 6 milligrams, 12 milligrams, and 12 milligrams, but you may have to increase the dose in that instance. Or you may have to decrease the dose, those patients who are more sensitive, in patients taking dipyridamole or carbamazepine, heart transplant patients, or those that already have central line access. This drug can cause chest pain in over 30% of patients, so you want to be very careful to give that in patients with severe CAD. But the patients who suffer from these arrhythmias are patients with severe CAD, so I find that amusing. Don't give it in asthma. It can cause severe bronchoconstriction. And the key here is that your rhythm needs to be narrow and regular. Don't give it if it's irregular, wide, or polymorphic. And of course, you can use AV nodal blocking agents in an SVT. Calcium channel blockers and beta blockers are going to block the AV node and try to slow down that rhythm, but you have to be very careful in Wolff-Parkinson White, where you can actually accelerate that accessory pathway with calcium channel blockers, beta blockers, and DIG. So be careful of that. Okay, so that was the narrow SVTs. If you have a tachycardia that is irregular, what is it? AFib. An irregular rhythm is most likely going to be AFib. So your focus in that instance is going to be to control the ventricular rate, and we're going to use verapamil, butalbitum, beta blockers plus or minus DIG in that instance. And as long as we get the rate below 110, it's really acceptable, and that's fine. We don't have to get them to a rate of 70, so you can be just enough to get them under 110 is acceptable. If you have a patient who is so severely symptomatic, though, that they become unstable, that is when you might consider cardioversion. And Dr. Wiggins is going to talk about chronic AFib. I'm just going to touch on cardioversion just for a moment because this is the acute side of AFib. And if the AFib is less than 48 hours of duration, the likelihood that they have a clot sitting in their left atrial appendage is minimal, and you can go ahead and cardiovert them. You're cardioverting them because they're symptomatic, they're potentially unstable. If it's been greater than 48 hours and you want to consider cardioversion, you should have a TEE, a transesophageal echo, to make sure and to look in the left atrial appendage of the heart and to make sure that there's not a clot, because cardioversion itself carries a high rate of stroke associated with it. And you know, when you look at the TAD score and you determine what risk the patient is of having a stroke over the next 365 days, I mean, if you divided that by 365, that would get your daily risk of stroke essentially. Cardioversion carries a risk of greater than 1%. So it's really high compared to just daily in and outs of living with AFib. You have to hang heparin when you do a cardioversion. You can use either heparin according to the ACC guidelines, or the CHEST guidelines in 2012 said you can also use low molecular weight heparin. The thing is, it has to be at treatment doses. But that is bridged and covered until the patient gets on an anticoagulant agent. And if the cardioversion works, then you continue that anticoagulant for 4 weeks after. All right, so you can cardiovert electrically or you can cardiovert pharmacologically. Most commonly at my institution, we kind of do a combination of the two. And drugs that are used to cardiovert patients, if you can remember DIP-AF, then you'll know the drugs that are used to cardiovert patients. Follow me, everybody look up here just for a second. DIP, dofetilide, ibutylide, and amiodarone are your potassium channel blockers. And then propafenone and flecainide are the two 1C agents that are approved for pill in a pocket. You know what pill in a pocket is, right? It's where they feel their AFib coming on, you give a dose, 300, 600 milligrams, and it converts their atrial fibrillation on their own. So that's a prescribing strategy that some cardiologists give, pill in a pocket approach for cardioverting their AFib. What's less effective and harmful, I would just know that DIDs and Sotalol are harmful. They're not recommended. DIDs is probably not harmful unless if you overshoot and they get toxic. I have a cardiologist on staff who is about 80, and he, every month, says, DIDs is great for cardioverting. I'm like, no, poor doctor, and I'm not going to say his name, but no, it's not. It's not really a great rate control agent as is, but he gets it wrong every time, bless his heart. Drugs that, if you are thinking about, if the AFib has been in duration for greater than 7 days, it's harder to cardioverse. And there's only 3 drugs in that instance. If you think harder and you think hard to treat, I think hard, stone, diamond, DAI. So these are your potassium channel blockers. Dofetilide, amiodarone, and ibutylide are indicated for that setting. All right, moving on from our irregular rhythms to a wide complex tachycardia. If your tachycardia is wide, it's most likely either VTach or torsades. So according to the ACLS guidelines, there is a new indication for adenosine in this instance. If you don't know what the rhythm is, but it's regular and it's monomorphic, you can give a dose of adenosine. And if it's a ventricular tachycardia, probably what all the adenosine will do is slow the rhythm down enough so that you can tell what it is. But that's a change. And if it's an atrial SVT and it's just a wider complex because it has aberrancy, then it might even convert that rhythm. So adenosine is appropriate in that instance, but it has to be regular and it has to be monomorphic. And your drug here to use in ventricular tachycardia is IV amia. The guidelines will say you can use procainamide or Sotalol. We don't have IV Sotalol in the United States, and that's what they're talking about. And it also says avoid procainamide and Sotalol if your QT is prolonged. And we already know they have a long QRS or wide QRS, and often these are patients who their QRS or QT interval is widening. So torsades is what we're trying to avoid. And torsades is a twisting of the points. It's polymorphic VTAC, and it's life-threatening. And if that patient has torsades as a result from a drug therapy that we may be monitoring in them, i.e., many of the antiarrhythmics, all of the class 1A, for example, caused an increase in QT interval, we may want to remove those agents. We want to look for drug interactions. There are many drug interactions that can increase a patient's risk for torsades. You want to potentially remove an offending agent if your patient has torsades because of a drug therapy. Defibrillate. If they are unstable, the answer is defibrillation. If they are stable, you can give IV magnesium in this instance. I just want to mention, and this is not in your handout, so I just want to mention that therapeutic hypothermia is now an option in a post-cardiac arrest care algorithm. Now, I can just see them asking one question that says, which of the following has been shown to improve neurological morbidity in the post-ACLS setting? Well, none of your drugs have, and hypothermia has. And granted, these are very small studies, but what happens is you resuscitate a patient, you've defibrillated them, they have had return of spontaneous circulation, but they're comatose. They're not responding really to you, but you've got a pulse and you've got a blood pressure. These are the patients that are considered for therapeutic hypothermia. You cool them to 32 to 34 degrees. Sometimes cooling IV fluids, that's kind of one of the older ways of doing things a lot. Now they have much more sophisticated machinery that helps with cooling blankets and very protocol-driven cooling techniques. But these patients who receive therapeutic hypothermia for 12 to 24 hours and you rewarm them slowly have had substantial neurological recovery at 1 year, which is outstanding compared to the fact that they just had sudden cardiac death. By the way, that's Dr. Ice. This is the protocol. It's not Dr. Emory House or, a code blue. It's Dr. Ice to the ICU. All right, this is also not in your handout, but this is for background. We're going to talk about chronic treatment of ventricular arrhythmias just for a second. And I want you to know the difference. Non-sustained VTAC is going to be a couple of runs of PVCs lasting less than 30 seconds, and it spontaneously converts on its own. If your patient is asymptomatic, usually no treatment is necessary. If your patient becomes symptomatic because of that non-sustained VTAC, they need to be on a beta blocker. If you have sustained VTAC, and there are 3 or more PVCs in a row, it lasts longer than 30 seconds, or it lasts less than 30 seconds, but something had to be done because of hemodynamic compromise. These guys are going to get an ICD. And we used to not have implantable cardioverter devices, and we tried drug therapy in this instance. But we know now that ICDs provide more benefit to these patients who are at risk for sudden cardiac death. Included in your handout are the indications of what Medicare will pay for in those patients who qualify for ICDs. I don't think you'll have to know all the ins and outs of that. Just know that mainly everybody has to have either a low EF, below 35%. These are patients who have demonstrated either through a EP study or they've had runs of sustained ventricular tachycardia, but they have to have a greater than 1 year life expectancy in order to get these devices put in because they're pretty expensive. But they are beneficial and life-saving. So let's run through an arrhythmia case. We've got a 60-year-old male. He's admitted for syncope. He is seeing black spots, dizziness. He passed out. He comes in. We put him on a telemetry monitor, and lo and behold, it shows sustained ventricular tachycardia. His blood pressure is okay. His heart rate's okay. And his labs are, he's got a serum creatinine of 2.2. His past medical history is significant for heart failure, MI, left ventricular hypertrophy, diabetes with nephropathy, and he's on standard medicines of lisinopril, Lasix, metoprolol, DIG, glyburide, and aspirin. So which is the best drug therapy to initiate treatment for sustained ventricular tachycardia in him? And I don't expect you to know the answer right now. Let's talk about a few things. I really like mnemonics. I shared with you my mnemonics for conversion of AFib. I have a mnemonic for the sodium channel blockers that I'll share with you in just a moment, but this is the Vaughan Williams classification of antiarrhythmic agents. We are very limited in patients with structural heart disease on which antiarrhythmics that we can use. So antiarrhythmics not only need to be chosen because of their efficacy in a certain area, but we also have to pay really close attention to their safety, because all antiarrhythmics are essentially pro-arrhythmic, and so the choice of one really highly can affect patient outcome. So the class 2 and 4, those are your AV nodal blocking agents. I'm not going to talk about that. We're going to come back to the potassium channel blockers in just a moment, because they're the most common agents you will see in patients with structural heart disease, or you need to choose them if your patient has structural heart disease. So what do I mean by structural heart disease? That's anyone who's suffered an MI, it's anyone with valvular disease, it's anyone with left ventricular hypertrophy, it's anyone with heart failure. So these are the types of patients who are high risk for arrhythmias, and we're going to stick mainly to these agents in those individuals. But there are certain agents among that class that are safer in heart failure, and we'll talk about that in a minute too. Class 1As, with the exception of some 1Cs, I don't really see them that often anymore. But we're going to talk about just a reason, like you need to know for the exam, if the patient does not have structural heart disease, you need to know which one to choose. So watch me up here, okay? Double, quarter pounder, lettuce mayo, more fries, please. Now this used to have tokenite, and I liked it because I like tomato on my cheeseburger, but it was double quarter pounder, lettuce, tomato, mayo, and more fries, please. Marizicine's not available anymore either, so you can cross that out of your table. You won't have to know that. But let's talk about the 1As for just a second. Let me go back. Let me point out that all of these, 2 through 4, are clinically relevant for both atrial and ventricular arrhythmias. But the class 1A are all different, and it's based upon 1A, 1B, 1C. The 1As are used for both atrial and ventricular arrhythmias. We know that there is greater mortality in those who are post-MI, so we're not going to use those in patients with structural heart disease. If you look here, torsades, torsades, torsades. If you look at procainamide and disopyramide, heart failure. They have beta-blocking properties. They're negative inotropes. We are not going to choose these agents for patients who have a compromised left ventricular dysfunction. Maybe in the outpatient setting, maybe you might see disopyramide used in vaguely mediated PSVTs, but it has a lot of anticholinergic side effects. I haven't seen quinidine used in 15 years. And of course, procainamide's not orally available anymore. The 1Bs they have less affinity for the atrial tissue, so they're mainly used in ventricular tachycardias. And lidocaine is always second line to amio. I rarely see lidocaine used. It's IV only, whereas mexilotine is PO. But there again, there's some significant side effects, CNS side effects with mexilotine, as well as lidocaine too. And lidocaine, you have to reduce the dose in hepatic and renal dysfunction. The 1C agents are mainly used for supraventricular tachycardias, and these are the 2 agents that are used for the pill in the pocket approach. So propafenone and flecainide, both have some of a beta-blocking property to them, so they are not for patients with heart failure. They can cause and exacerbate an acute decompensation. And think drug interactions when you think about these agents. They increase DIG concentrations, they'll affect warfarin concentrations. So in my practice, we don't go to these, but you might see this on the exam as a drug interaction type question, so be aware of that. The class 3s are what we generally use a lot of, and I'm not going to talk about these because I think Dr. Wiggins will cover these when she talks about atrial fibrillation. The only thing that I will point out is that sotalol and dofetilide, Sotalol can be used for ventricular tachycardias. Defetilide can't, but these two are renally cleared. So put a star by those. Those are your renally cleared class 3s. So you're not going to use those, or you're going to dose adjust in renal dysfunction. Sotalol is contraindicated in a creatinine clearance less than 40 for AFib, but you can use it still in ventricular arrhythmias. You just have to separate the dosing interval. You might get every other day dosing or something if you had extremes. But I call this agent Sotalol. I wrote a paper about my experience with Sotalol in the community setting, and a physician who just loved it. He gave it to everybody, and I had these poor little elderly women who were 80 coming in, and not only was their renal function compromised, but they were having bradycardia. They were having shortness of breath. I wonder why. Sotalol's 50-50, beta blockade and potassium channel blockade. And so when we would try to intervene and say, just stop the Sotalol, we saw him put in pacemakers. Awful shame. Read my paper if you're interested more. Amio is probably one of the ones that we go to a lot, and it's used for both atrial and ventricular arrhythmias. Ibutylide is only for conversion of AFib. It's a double bolus IV agent, and I am not going to talk about trinitrin. So when you have a patient who has heart failure, i.e. left ventricular ejection fraction less than 40%, avoid sodium channel blockers. Amiodarone and defetilide are your two that are safe in AFib and heart failure, and amio is the one that we go to for ventricular arrhythmias because defetilide's not indicated for that setting. Defetilide also has data in post-MI patients. All right, so what's the best therapy for this man? This is a long time ago. He's got serum creatinine of high, and he's got a poor creatinine clearance. I think it's less than 30. He's got heart failure, left ventricular hypertrophy. I only see 1A. You are right. That is the right choice, amiodarone, for this individual. I have 5 minutes left, and we're going to finish up by talking about hypertensive crises. And when your patient has a hypertensive emergency, it is not the value of the blood pressure that determines whether or not this is an emergency or just something that we need to observe. It is the presence of acute target organ damage that makes the difference. So target organ damage can be chronic. I mean, I've got chronic kidney disease, or I've got peripheral vascular disease, or I have a reduced creatinine clearance. I'm talking about progressive acute target organ damage. And so I would hope on the case that that would be clear on the exam, that they would be very clear. This is ongoing acute dyspnea on exertion, pulmonary symptoms, an acute high elevation in blood pressure with chest pain and acute coronary syndrome, those types of things. So it's not the blood pressure that dictates whether or not it's emergency or urgency. It is that presence of acute target organ damage. And there's no typical presentation. It can affect any of 5 organs: your eyes, your brain, your heart, your lungs, and your kidneys. So all of these down here are examples of those target organs that can be affected, but keep in mind it's got to be progressive and acute. And if it is progressive and acute, this is pretty emergent. This is something that we are going to admit that patient to the hospital. We are going to use IV medications to take care of them. We are going to admit them to the ICU so we can monitor their blood pressure very, very tightly. And the thing is about when you choose a drug to treat, they're all going to be IV agents in an emergent situation. This is not the place for oral medication therapy. But, well, I forgot what I was going to say. It was really good. Okay, don't overshoot. Do not overshoot. You're going to bring down the blood pressure slowly. The body has this amazing ability to maintain central perfusion pressure across a wide range of blood pressures. And that's called cerebral autoregulation. But when that fails, and it fails when you have a hypertensive emergency, you cannot drop the blood pressure very quickly. Otherwise, you will cause more damage than you started out with. And so the goal is to lower a mean arterial pressure by no more than 20 to 25% within that first hour of therapy. Many clinicians say, and these guidelines are I mean, it's in JNC 6, JNC 7, but it's not highly talked about. Some clinicians these days say that even an approach to reduce the diastolic blood pressure by 10% or 15% over the first hour could be appropriate as well. But don't choose more than that. Urgency is going to be, these patients do not need to be admitted to the hospital. These patients can be taken care of with oral medications where you may just simply, a lot of reason that patients come in with hypertensive urgency is because they haven't been taking their blood pressure medicine. Maybe they ran out or didn't get their prescription filled or they're non-adherent or whatever. So you can just restart their home therapy as long as, I would make sure they are on at least 2 agents at that point in time. Depending upon how severe the patient is complaining, they might go ahead and keep them in the emergency department for a couple of hours to observe. And there's a table in your handout that talks about very acute or short onset oral agents, but these are not necessarily agents that we're going to send them home on. Oftentimes these patients can just be restarted on their home medicines. Okay, really quickly, 68-year-old man comes in, he's had cocaine along with his barbecue, he's non-adherent, he is complaining of an ACS. He's brought to the emergency department with a very significant blood pressure, but the real thing is that he has acute progressive target organ damage and he is showing ST segment depressions in his inferior leads. So of the 4 options, what is going to be our option to treat him? Right away, you can eliminate 2 responses when you critically evaluate them. We're not going to do a 50% reduction. We're not going to use oral medicines in this instance, so it becomes nitroprusside or IV nitroglycerin, and we've spent a lot of time on why you would choose nitroglycerin in an ACS setting, so the answer is that. There are a couple of tables in your handout that I would highly recommend you just look at. It gives there's no preferred one agent over the other, but there are going to be some information where you might want to avoid a certain agent in, for example, nitroprusside in someone with renal disease. Okay, I'll leave you with this. Read very carefully and critique the question stem. Take a deep breath. This is going to be okay. Try to eliminate 2 responses that don't make sense given the details of the case. Focus on drug-drug interactions and maybe contraindications to drug therapy. Study for this exam. Don't take for granted that this is going to be easy. And the night before, get a great meal and sleep at least 8 hours. I leave you with that. I will remain. You guys go take a 10-minute break and then we'll go into Cardiology II. If you have any questions, you can come find me.